Welcome everybody. I figured I'd try to decorate a little bit, just in case you're wondering. Yeah. Coffin traveling flask, in case you wonder what liquid death is, it's water, if you haven't heard of it. So anyways, one thing real quick, I want to ask, how many people are biomeds? How many are medical imaging? Any ITs in here? Oh, we got a few guys in here. Okay. I'm all three. So what we're going to talk about today is more experience of what I've had to overcome and my challenges of putting biomedical equipment in the IT world. I go back to some of my network installings back at the University of Michigan back in my first life when I was a technician long before I became a manager. So we're going to flip through a couple quick slides here. All this will be online, remember that. And my goal of this is, as was stated in our prior presentation, I could talk about this for 4 hours. I'm not going to keep you from beer, okay? A little bit about WellStar, where I'm my current employer. Something to think about. If you never fail, until you stop trying. Albert Einstein. The catch is, what I've learned in my career, there are a lot of people who come up to me and said a lot of smart people tried to take on this task, but a lot of times where I've succeeded is I'm a lot more determined than they are, because sometimes people will look at something and go, I can't do this. If you think you can't, you're right, you can't. But if you're willing to persevere, you can overcome it. A little bit of my background. Had my 4 lives right there. Actually had all 3 different lives and technical lives. So some of the things we're going to talk about here, all of you guys have survived our first one, the COVID pandemic. Some of the things that surprises. One morning I woke up and basically I was working out in the gym and heard a few doctors talking and said, guess what? We're shutting down a hospital. And I was like, what? Isn't that great when you find out stuff like that? Unfortunately, in one of my lives, I was also in a county hospital up in Chattanooga, Tennessee, called Erlanger, and we would find out everything that went wrong in the newspaper. And unfortunately, that was not the way you like finding out things. Acquiring a new hospital network, that was my other surprise. We went from the villain of Atlanta last year to the savior of Augusta. So we acquired 4 more hospitals. We went from 11 to 9 to 13. So expansion's the service line. So things to remember, things to ponder. Bring your own devices. How many people, this goes back, how many people now use your cell phone at work routinely? One of the things that a lot of people don't realize is, technically, depending on how you use your cell phone, you now brought yourself into, technically, your cell phone becomes property of your employer. I have a habit, I have 2 cell phones. I have one at work, I have one my own. They crisscross a lot. But, the bring your own device problem you have is anytime you bring anything into your hospital, you bring in the chance for intrusions. So basically viruses. No different than COVID. Anytime somebody walked into a hospital at one point, there's a possibility of COVID. Mobile devices, device mobility has increased. If you think about it back, how many people have been in this field over 20 years? I'm not going to go through. Raise my hand. I remember the days when we just had a one-way pager, and the stupid thing beeped when we call your name, call your call sign out. Mine was 1877. Report to trauma. How did you tell anybody you're on your way? You showed up. So the average healthcare data breaches, this is, it's now up to 10.39 million, up from $10.10 million in 2022. I just found out, I got a notification that my old retirement plan at the University of Michigan completely got breached for me and 3 of my kids. So they're like, so this tells you how easy this happens. My healthcare, my former employer, McLaren Health System, breached earlier this year. I know we had a breach, not a real big one at our hospital, but if you just listen to the news, this has become so prevalent. And the cost of, 40, 30%, part of the problem is it's not only external people, there is a lot of people who are trying to get in. Internally, a lot of people open the door by mistake. So 43% of all breaches are insider threats, either intentional or unintentional. So people will not have, they'll allow computers in. And so we'll talk about some of this other stuff coming up here. EMR and PACS. One of the first things I started when I came to my current position was we had a EMR called Epic. And one of my background was in IT also. And so the goal was to bring an Epic system online, an electronic medical record. Quickly, when I switched into my new job as a manager of medical imaging services, PACS, basically all my equipment takes a picture. So that's basically our fence divider between the biomeds and us. Now we're a little unique in our place because the biomeds are on the IT side. 25 years ago, medical imaging services was spun off to radiology. Biomed wanted no part of us. So we were kind of the stepchildren nobody wanted. So up until I came on board, there really wasn't an engineer that ran my department as a radiology tech, which there's one good point. If you break your leg, you're an employee, your boss can take your x-ray. Currently, you don't want me to take your x-ray. So now I can fix the machine, but a little bit different. Types of device security. One of the problems you have with any type of device is physical security, limitation of access to the device or system. You have to bear with me a little bit. I broke my one set of glasses, so I'm kind of flashing back here a little bit, okay? Let me move over here. Prevent removal, controlled access to areas, virtual security, documentation of operating systems. How many people have all their operating systems documented in their database? We got a couple of them out there. I'm struggling because I keep getting new hospitals that have no information on them. Antivirus software, other issues, cameras, everybody knows cameras are a no-no. And we actually had one interesting breach back at One Life. We had a group of people who are called SEALs, basically Service Excellence Action Leaders in my one hospital. And one of the goals was you would take pictures of your group and submit them to say, hey, look how good we're doing. One of our groups, the first one out of the gate, didn't realize what they took their picture in front of. It was the whiteboard in the nurse's station that had all the HIPAA information of the patients back in the day. Does everyone remember those whiteboards where you walk down the hall and the patient's names are on it? And some of the challenges we've had recently, as I mentioned, we were kind of got a little bit of a black eye. The level 1 trauma center we had to shut down in Atlanta. The reason why we did it was we were losing so much money that being the type of hospital we were, there's 2 hospitals, Grady and us, WellStar. We couldn't support it. We were losing $133 million a year. We just had to shutter it. But what happened in that time is a lot of the devices we didn't have, we did have that controlled access, but some of the problems you have is limited physical access to a device or system. Can everybody, if you put a row of PCs out here, how many people can identify the one that attaches to a CT system, a mammography system, your desktop, or the patient access system? It's pretty much nil. So one of the challenges you do run into is the education of, and this is nothing negative on IT people, but a lot of the beginning IT people are trained that they will go into an area and they'll survey a bunch of devices, and there's not that differentiation between A is patient care, B is IT. So you end up with a different set of challenges right there. Internal inventory. One of the things that in my world, I got my bachelor's of science degree from Eastern Michigan University. My background, my experience, the educational background of my staff, and one of the problems you have today is a lot of some people are gung-ho to learn this, some people are not. Prior experience, not only with your staff, but other departments working with you. Certifications, one of the things we did a few years back, in fact, 2 times. One time, our IT department at the University of Michigan made fun of us and said, there's more certified biomeds in our department, which is true, than you guys. So what happened to be is, in our world, we had a little throwdown. We said, oh yeah? So we managed to be the first department that did a specific certification. So 6 of us became certified in one shot with Amy's blessing. And we did a college class to prove to our IT department, who are former biomeds, that we could, okay, tit for tat. We're certified, you're certified, knock it off. Now, one of the things we did run into, fast forward now into my next life at Erlanger, one of the things was I became part of IT, which was a division called technology management. Clinical engineering was buried inside technology management. So if you can imagine this right now, during a budgetary crisis, clinical engineering, in order for them to survive, became purely part of, not even, purely part of IT blended. The imaging group that we had there was completely a separate entity. So that presented a whole bunch of problems, but it also identified when I started there, one of the first tasks I had was make clinical engineering its own department again. And as I started working with people, the one thing I did realize, there's a little bit of that same thing, the tit for tat of certifications. If anybody works with anybody in IT, they have all these initials behind their name, certifications. So what happened was, when we started working with networks, one of my guys at the time was going to college at University of Tennessee, and he started taking these certifications. He had all sorts of Microsoft certifications. What happened was, there was a point where we sat down at a table and said, we need to gain more access. We need to work with you more. And they said, well, we've got this. I got Microsoft security. I've got this Microsoft certification. I've got that Microsoft certification. And I pointed right next to me and I said, he's got all those. So guess what? We created our first biomed specialist. So he was so that helped us out immensely. Understanding components, know all your pieces, have all your staff. Depends on, a lot of people today, the good news is I've been in education on the biomed side since I was a volunteer at my first college, Eastern Michigan, second Schoolcraft College in Eastern Michigan, volunteered on a lot of college boards. Understanding all the components and helping out, you're getting access to anything you can for your staff to understand this stuff. Network designs, topology, stuff like this will come back and literally it will bite you. Because during the biggest system I had installed was in 1999. We did a project that was basically the biggest patient monitor system in the country in 1999. And so it's the University of Michigan healthcare system. It encompassed our main campus. It encompassed a children's hospital. It was a elaborate network. And there was a lot of challenges because when you're evaluating the different designs and getting IT involved, there was a lot of challenges, especially back in those days, because there was a lot of limitations. Anybody remember the old days of Philips monitors, signal distribution networks? I'm sounding old here. Okay, we'll move on. All right, common ways to exposure equipment to the network. Outdated, unsupported software. This is something we're dealing with right now. My favorite software in the whole wide world at one point was this lovely thing called XP. Everybody remember it? I loved XP. Unfortunately, Microsoft quit supporting XP. And so a lot of our devices were XP. CT scanners, MRIs. There was another component that was called embedded XP, which was the main kernel of XP, which was later found out to be breached. Third-party vendors, do not utilize some of the same protection measures. And you'll see this device coming on a little bit later on in here. The medical devices with open access to the internet, we are still struggling with the same issue after 15 years in 3 different employers. The biggest thing we have is everybody has basically EEG machines, right? Sleep studies. That was one of our arch nemesises because they had open access to the internet, and part of their argument was, when we're talking to a patient, we may need to find a health aid. There's things that legitimately you do need. If you have somebody who's having seizures, things like that, you may need to reach out. I need helmets. I need this type of adaptive technology, coordination of care. Unfortunately, that's the honorable thing to do, but also you find Belk, you find eBay, you find all these other sources that they're going out. And so even today, we're working on some of the devices we're finding. We're doing network surveillance to see who is going places they shouldn't be that slip through the cracks. Unencrypted USB drives. We had at my past life at Erlanger, everybody was assigned basically a USB device called an iron key. Each one was serial numbered, logged to the person. So that was your thing. So if you lost it, they knew exactly who lost it. It was like my early days when we had our hospital keys. They punched an ID into it. Your keys were stuck somewhere. They knew exactly who lost their keys. Open USB ports on any device. This is a huge challenge. We had back in probably around the 2012, 2013 timeframe, one of my workstations in the cath lab, somebody decided to plug in their phone to charge in the USB port that we didn't know was there. And that was, at that time, I was, pretty much, I was clinical engineering, but the medical imaging group was our siblings. So they were directly down the hall from us, but they were under a massive contract by an insurance company. So we did the repairs, things like that, but things like USB drives and stuff like that weren't really that much on the radar. And the fortunate part was the first person who saw a workstation getting corrupted immediately had that, oh crap moment, and basically pulled the plug on the station. So we managed to get up there pretty quick. We did have a lot of damage to it. We had some damage to that one, but we managed to keep it from going on the network. Unauthorized software installations. Our biggest thing right now, the biggest nemesis that keeps getting worse and worse and worse is social media. Social media, everybody wants to go on Facebook. Everybody wants to go on Instagram. Everybody wants to go, the younger people have so much more than I don't even go on. So unsecured laptops, one of the issues that currently has, and this isn't only laptops, if you consider what my lovely phone down here, my Samsung is, it's a lot more powerful than that laptop I was worried about 10 years ago. And one of the issues is, depending on where you're at in the one environment, Erlanger was in an inner city. And so it was common to have occasionally people sneak in, roam around, and anything that looked like a laptop was potentially money. Believe it or not, there was a point in my career when I first started there when all the pawn shops within a 5-mile radius knew me and had my business card. And there's an extra funny story because my brother was in downtown, worked in Detroit for a hospital network called the Detroit Medical Center. One of his Dynamaps was found at a garage sale for $5 by one of his techs. So, and so everybody, believe it or not, this stuff gets out there. Laptops, quick way to get $50. Protect your equipment, never share. Does anybody remember the days when the vendor would give out basically the admin password to your systems? There were so many days that I wanted to get a hold of a vendor and literally strangle them because they said, hey, congratulations, you've just built this lovely new monitor system. Remember my one at the University of Michigan? We're going to give the admin password to everybody. Fortunately, we caught them and we said, no, you're not. Ensure proper access levels with users. That is one of the issues when you give out those passwords. If you have an uninformed person can do more damage than, you would imagine. Limit access to the outside hospital network, no internet unless absolutely necessary. Remember I talked about that EEG machine? It is a bit of a fight. And also the other catch, I'll be honest with you, in my real world, I have my desktop computer, I have my work laptop, and I also have what I call my pirate. I have my own laptop. So why do I need that? Because every now and then I need to research a component for a system, or I need to find something. I'm blocked from every auction site on both my work computers. And you'll see some other stuff. I've managed to build a whole bunch of stuff off eBay. So lock USB ports physically or by software. Oh, there we go. So, went too far. So these guys right here, these slides are available. This is a company out of Huntsville, Alabama that I've worked with in the past. They make port lockers that basically, they can make them custom to your hospital, connectivity center. They have them color coded. You can use them for different areas of your hospital. You can use building to building to building to make sure that somebody who has the key to unlock it can't walk from place to place to place. So these things are great. Desktops, laptops, you can see some of the physical locking devices. This is one of our laptop offering they had. One of our first urology systems that became a concern to us, that was years ago at Erlanger, was it literally came in as a physical laptop, an HP. And the department wasn't at all concerned about it. They said, just leave it on the cart, all is good. And I said, well, you do realize you're a clinic and somebody can just walk in and what do you see? You see a laptop. Remember I said every pawn shop knows me? There's a reason for that. Understanding your department's internal boundaries. Currently in my world right now, I was part of IT when I worked for biomed. The good news is they stuffed me on the 9th floor of an office building. So I made the joke, there was a biomed and there was like 1,000 IT people. So I was a little outnumbered. But the good news was I made the joke about, they put my cubicle, I was right by the bathroom on the 9th floor for all the main IT people. So everybody had to walk by me and meet me for about a year and a half. So I made a lot of relationships with people because I was always in the same break room with them. So the biggest thing I can tell you is reach out. If you haven't reached out to your IT department, do it, because the better that they understand who you are, that you're a partner with them. I don't want their business. Hopefully they don't want my business, because has anyone ever seen, and this is not a bashing thing again, but when we were doing that Epic project, when we walked in an active OR that had just come out of a surgery case and there was blood or something that somebody was cleaning up and we're working back in this back corner where nothing's at, to a biomed or somebody in IT, in medical imaging who has been exposed to that, it's no big deal. You know what not to touch, you know what to touch, as soon as they open the door, they're like, boom, I'll wait out here until you guys tell me it's okay to come in. Or if there's a problem with a patient on the table, they do not come in the room. It's just that you're not trained for it. It's nothing negative. They were not, you don't go to college and, learn about IT to walk into some of our environments. What are the limitations of access into the IT environment? What is the relationship with the IT provider? Currently, I'm in-house, which is great. In the last life I was in, we were in-house, but we were controlled by, in fact, the last 2 lives, they were controlled by a third party, the IT was. So that's another challenge. What's your relationship with your IT provider? Internally, that's why I said build that relationship. If they're a third party, there's a lot of other hoops you're going to have to know what you can and can't do and who to talk to. What are your employer's limitations into the IT environment? One of the things right here, I do a lot of projects. Who pulls cables? Who does network checks? Who assigns IP addresses? Basically, And then another lovely thing that was my new environment was our AE titles. Everybody know about those things? That was something not in the biomed world. First thing I walked into when I took my job over at Well as medical imaging services manager, they decided to upgrade their PACS system. So I had about 3 weeks before somebody said, hey, guess what? By the way, we need to know all your IP addresses on all your devices that match the AE titles. And that was, and at one point, believe it or not, this group, the PACS group, was actually within my group. They were like married. And I made the joke that they sent them over the IT building and they brought me back. So literally, they went to the 9th floor. I came back into Kennestone Hospital, our mothership. But what nobody ever bothered to realize was all of our devices are tracked by a thing called a tag number. In our world, it's called an N number, Nancy number, N and six numeric characters. So when they started putting this together and said, okay, we're getting ready to reach out to CT number, AE such and such. We're like, we don't hit, we realized right off the bat, you might as well have been talking Portuguese and German. We just went right past each other. Now, the good news was, one of the people over there, when I said I was on that 9th floor, the head of connectivity started working when I started working there, Ron. And so we just happened to be new in the department. So we happened to be friends before I took that job. So we both agreed we're still working on this right now, but we already had a good relationship with each other. But they are the guys who assign when we get a new piece of equipment, we go right to them. Back at my old life, we had our biomed specialist who could reach out and do all the paperwork and get everything pushed along a little faster. Meeting attendance, everybody, I think one of the most painful things I'll mention is there's a lot of times you end up with meetings that you go like, boy, I'm really busy, but they are very important. Are any issues connecting to, to these planning meetings? Understanding the topic of the meeting, how it does not impact, I use my imaging devices because right now if I lose connectivity, everything that I send a picture is money. Now I went to a whole different world that in IT, there was nothing that said patient care dictated my raise or dictated my boss's raise. So it's not something you're worried about. Now, with PACS and all the issues of patient care, radiology, my boss is a VP of radiology. So she is not technical, but she is very, on the patient care side, it's a whole different world. IT security, one of the things that they realized that when I was there, they reached out to me and said, hey, we're going to reach out to you on we want you to be on all the InfoSec calls. I said, sure, I will gladly do that because I realize the importance of it. Formal process, find out if whoever you're working for, I'm still like with the 4 new hospitals, we're still learning. We integrated so quickly that, learning how they're rapidly assimilating to us. They became WellStar, we didn't become them. So I do know what eventually is going to happen. Who determines the priority lists on requests? One of the simplest way to look at it in our world, in the biomed IT world, not IT world, but medical imaging world, we have to find, I know how long it takes to make an MRI. I know about how long, we can predict how long it takes to do construction, removal, reinstall. The wild card, and this was an eye-opener for me back at Erlanger's, there was a contraction in healthcare. Everybody at one point, all the doctors went away. Then rapidly they learned they were getting more reimbursement by coming back. So rapidly we had a contraction in like the Chattanooga area of these doctors coming back. And so the catch was we could get their equipment back online. We could order new equipment, but it took them so long to build basically the billing components. So they were, I think, backlogged at 1.6 months. We were like 4 weeks. So we said, we're good to go in this amount of time. We did the survey, and They said basically not going to happen. So, you know, and the other thing is in this, and this has been something that's a little bit I talked about on the project management, you know, on the IT world, if you put in a device, make sure to bring up any type, who is paying for, remember I mentioned that cabling before? Who is paying for it? If you don't see it, make sure that you put some sort of notification out that says we need money. Because, you know, we're getting more and more wireless stuff, but it's still not there. Also too, wireless networks are still, you know, there's still issues with those, kind of where you're at. Software information, IT support, any secure any software license documentation immediately. There's actually kind of a good bad story that happened. We had an MRI scanner that was serviced by a third party. We have a massive contract. And what happened was somebody knew Joint Commission was coming. So they went into the MRI, basically work area where all, I call it the brains are. And what they had out there was they had all the software disks for the backup of this antique GE MRI. And they said, oh my God, we have to clean this up and just get rid of everything. So they did get rid of everything. Unfortunately, nothing happened to that device for, you know, in between PMs, there was no calls until one day it decided to take a power bomb. And they went to restore the software and the disks were right over there. When our Philips multi-vendor people came in, they were not there anymore. They had been thrown away probably 2 months before. So they, unbeknownst to us, it was a physician's office. It was basically not an imaging center, but it was like a physician's office on steroids. So what happened was that MRI, but it was a 20-year-old MRI that we had on, that we knew was on borrowed time. But there's no way to recover it. GE, you're out of support. You know, basically any other third parties, you're kind of SOL because everything's gone. So make sure we had a secure place in my prior life where we kept all of our license documentations. I remember GE at one point told me if you lose any of these licenses on your patient monitoring system, it's tens of thousands of dollars if you need to do an upgrade. They don't have that anymore, but it was physical, actual licenses that we locked in a file cabinet. Any loss, there we go, any loss of software license, it was a nightmare. Storage area should have limited access, you know, ideally locked and secured, make backup copies if you can, create a secondary storage area, which is, you know, we always try to do, document everything. Right now, our struggle right now, like I said, we're struggling to catch up with documentation. I'm a very lean shop, and unfortunately, I have one guy who is really IT savvy along with me. That's 2 of us for 13 hospitals. So it's going to take us a bit if we had to do it by hand, but the good news is there's a lot of automated technology out there that we're looking forward to. We've been working with Palo Alto. We had a Zingbox originally that didn't quite work out, Palo Alto, and I know that didn't quite work out, so we're moving to our third one, which we're hoping will work out and automatically populate our database magically with everything we need. So, hardware requirements, specifications in writing, operating system software. People will sell you systems even, you know, everybody knows about Windows 7, right? Remember I said my favorite thing was Windows XP? People are selling XP devices within 12 months of the out of support. They're selling Windows 7. Now we've just had a whole big discussion about on our network surveillance. First thing that came up was one group of my devices that was identified as Windows 7. They said, this is a vulnerability. And it was something that I already knew I had to leash this in. And I'd already started talking to one of the vendors. This isn't a, you know, 5-figure, it's pretty much almost a 6-figure upgrade to all these x-ray machines, but it's something that needs to be done. Everyone agrees with it. But the good news is we already knew it was out there. You know, who supplies what and right, you know, when you're doing anything, go back to like network design, who does what in writing, use of OEM versus alternative suppliers. We had an issue with a wide area telemetry network I was working on. We were putting a major installation in. There was a big tit for tat between our IT person. And in fact, it was almost to a yelling match between me and him because they were a Nortel, our hospital was a Nortel show site. And so, but unfortunately back in the day, GE used Cisco router, every other network equipment was Cisco. And once you start deviating, and we had a whole discussion about this, he said, this is, it's the same device. I said, no, you don't realize that when they go through FDA qualifications, they submit their design at that point. And as soon as you start swapping pieces like that, you become the owner of it. And so that you call GE or something like that back in that time frame, you basically become it is painful. Now there is a lot of stuff, mix and match components. I never bought a laser printer from my OEMs. I go out every chance I could to Office Depot, displays, everything like that. If I could source it from somebody else, I bought it from somebody else. A lot of my vendors hated me. But, bottom line is I'm not going to spend $2,000 when I can spend 200. Vendor security, process needed to, accounting and purchasing department. Right now, we have a company called Green Security. Any of you dealt with those at all? That's our new security department. Basically our vetting, who's in charge of the process of agreements with the vendor. Ensure vendor and any staff are properly registered. Everybody in my world goes directly to me. So anybody from Philips, I walk them right over. I get their ID tags, stuff like that, so I know who's who. Who's in charge of processing agreements with the vendor. Right now, I write, in the medical imaging world, I write 100% of the contracts. That go right to legal. Which the good news is, I write them all. The bad news is, I write them all. The good news is with this one, we have a lawyer in my past life at my 2 employers back. I had to discuss with my vendors that the state we were working in is Tennessee, not Massachusetts. So every time I put something to a lawyer, they'd say, you know better. State of jurisdiction, they would give me the list of the hot points. I would have to argue with the vendor to get this before. And I said, you guys are the lawyers. So the good news is I don't have to do that anymore. Make sure the agreement will, for what information a vendor or service provider has access. We keep our stuff locked down pretty good. All of our MRIs are on, remotely monitored. They know something goes wrong before Philips knows what's going on before we do, which is great. So about probably 50% of the time, they'll catch something wrong, they'll remediate something without even coming on our house. HIPAA, our favorite thing in the whole wide world, isn't it? Remember I just mentioned our retirement accounts got hacked? Now everybody's got everything from our new addresses, our old addresses, all that cool stuff. Social security numbers. I don't even want to know when I read the letter when I get home. But, where the binary interface to PACS, EMR, one of the things we just got looped into is point of care ultrasounds, which are, depending on where you're at, a lot of biomeds do them. Years ago, in the 1990s, I did ultrasounds as a biomed. That's something that now came into our world because it's basically billable, because a lot of the stuff they used to do back in the days, like blocks and things like that, just were a note into the medical record versus a picture into the medical record that was billable. So remote physician access is needed. We have a lot of our, like right now, one of the areas in my particular department, we set up all the physician reading stations for the radiologists. Who owns the computers used for remote access? Had a huge issue in one of my places with that. We had a doctor who threw a fit that he wanted all the softwares in an adjacent office building so he could access his systems across, probably only about, I'd say about a quarter mile, let's be generous. What happened was he didn't keep his child from his computer. He would bring him occasionally into work when he was doing stuff and say, just go have at it. What he didn't realize was, remember I said, How do you get antiviruses in? Your own employees are sometimes your worst enemy, and that's what happened. Hospital policy for remote access. And like I said, we were really unpopular for a while there with that doctor, but he did have to agree that, we're locked down now. In-house testing. I'm not going to keep you guys for free beer, so I'm going to be quick. Purchase the test equipment. I know my first network surveillance device was $35,000. Developed in testing area. Let you read that real quick. We'll move on. This is what I built at one of my sites. All that stuff was salvaged from prior projects. What you had there was a training area with all the patient monitors. If somebody had a problem in one of the ICUs, you could go right in there. You could see anything at any location. Difference between an opportunity and the dead end. Most of the pitfalls, you get into, supporting devices not directly associated with a patient or providing, basically patient care. Try not to get into stuff that's not in your wheelhouse. I talked about my project management. There's lanes that are going through. Don't jump out of your lane, because once you start jumping out of your lane, some of the things that people try to get you into, admin side, you're the admin for a new system. You do not want that. User access for nurses, radiologists. Don't care. IT does that. We don't do anything with that. We can't manage it. Working, like I said, in the system administrator, taking on any role outside your skill set of your staff. Don't agree to anything if you don't know you have the capabilities of doing it. Good opportunities. One of the things that, this was actually, the SolarWinds was a system we had that we actually bought out of one of our projects, that wide area telemetry system. Our techs were really kind of peeved at me because we agreed to it. We said, they said, we need $100,000. Had the money, gave it to them. They said, went to the first training, and these guys were IT. Basically, I said, just sit there, don't say a word, just learn everything you can, and I've got a plan. So what happened was, they came back, and I said, they want nothing more than this for their network. What they're going to do is, as soon as they come back to our equipment, they're going to hold up their hands and say, it's all yours. And so it took about a month, 6 weeks. Then all of a sudden they came back and said, all those patient monitors you have on that network, the telemetry system and all that, that's all yours. Remember that network specialist I said I created? That's where he came into play. So we had all of our stuff. We had a beautiful virtual network where we could tell anything that was going on anywhere out of that command center. Palo Alto, mentioned that. Unfortunately, my current experience with Palo Alto is going the wrong way. BrainsGate, what BrainsGate was a system. We had a really sharp neurologist that probably one of the smartest men I've ever met. One day he was an electrical engineer, and one day he woke up and said, I'm going to be a neurosurgeon. He not only became a neurosurgeon, he became one of the best stroke doctors in the world. BrainsGate was basically a device that it put two basically needles in your upper palate of your mouth. And what happened on the onset of a stroke, it basically shoot, do this layman's terms, shoot a gas up there, dilate the vessels in your brain, and would immediately reverse the effects of stroke. Because what happens is, if you don't stop a stroke, everything starts dying. Because as soon as the blood supply is gone, it's a bad thing. The good news of that system was, the good news, bad news, well, number one, when it came in from Israel, that was how we made our relationship. He was concerned about it. He was somewhere else in the country. He said, this is coming in. I don't want it to disappear. I said, I will promise you, I will sit in my office right next to me. It will not go anywhere. And that was how we started our relationship. It had zero antivirus software, nothing. They said, we're great. We're going to go on the network. And that was where we got IT involved. We said, we don't think you understand. We're not worried about you, because this is brand new, getting anything from us. We're worried about something coming back to you because you have nothing. So Joe and one of our IT people, that was his name, Joe Watson, worked together, and they busted their tails. And one day, right after they got this done, a patient presented in our emergency room. dire needs. They used this machine, and basically what happened was the patient walked out the door 48 hours later. Before this machine existed, he would not have walked out the door. So when you think about the impact you have on life, changing this person had their magic bullet coming from them. This machine right here and the work of two people busting their tails changed that whole trajectory of this person. Planning stages was the purpose of the equipment being replaced. Always talk to everybody, find out what you're doing. Is any clinical staff, I cannot stress how many times somebody's not talked to a clinical person. The support requirements of the new equipment, that telemetry network I mentioned, there was a lot of money we had to put into test equipment, and we also, because it was a Sprint, basically a Sprint cell phone network running through our building, we had to work with Sprint. The good news is they wanted us to work with them. So all my guys got to, basically do some really high-end communication stuff. How critical is equipment to daily operation? Long-term support issues. Data storage. This has become better and better, as data storage is, decreased immensely. System administrator, I keep harping on this because you would be amazed how many times somebody loops themselves into something they don't need to. No such thing as a free puppy. I'm making sure I'm not keeping you guys, okay? There's certain, just because you can doesn't mean you should. There's the bottom line that comes down to it. Remember I showed you that test room that was salvaged all of our junk? All that stuff we knew we could reuse. We made sure of it. The condition of devices, watch for leftover, free leftover equipment. So we did on a lot of times was in our world, we were a poor county hospital. We got all of our money, we basically gave at one point, that one hospital $100 million a year in uncompensated care. We were always broke. That was the first thing I tell a vendor when I talked to him for about the 15 years I was there. Hi, my name's Greg, I'm from Erlanger, and I tell you I'm broke. So we'll see how that one goes. This one's not open. So, just because you can, doesn't mean you should. Some of the issues we had, that actually backfired on us was, I remember one time they had some network cabinets. One thing IT does is IT doesn't move things. Once they put something down, a rack never moves. Unfortunately, we found out, unbeknownst to me, I was on vacation, there were a couple racks laying around that were volunteered on that system. What nobody realized was they threw out the wheel kits. So these couldn't move. They were pushed in between two command centers. So we had 4 command centers in the room. These things would have to move in and out, in and out. Once you start mounting all the equipment in it, these went from, maybe 150 pounds, if that, to well over 500, 1,000 pounds. So we had to come up with ways to lift these stupid things off the ground to get wheels under them. So that was we saved, I shouldn't say we, the person who made the decision saved a few bucks. Unfortunately, it didn't work out, and that was my 40th birthday, this was another story on that one. Years before I started working at Erlanger, I was also a telemetry expert in my first life as a biomed. They reused a whole telemetry, they used a whole telemetry antenna infrastructure from 3 different vendors to create this really first version of that wide area telemetry network. They asked the vendor, can we use it? And they said, well, kinda. And the answer should have been no. The first thing you should have said, no, we shouldn't do this. So what happened was, somewhere down the road, we were getting ready to replace this thing because of outdated CPUs. What happened was it had a catastrophic failure on my 40th birthday. So I got this call. This one whole floor was completely knocked out. And so the first thing I did, because, at this point I'm a manager, I'm not playing in the ceiling like I used to. I still go out quite a bit, probably more than most managers. First thing I did was I opened up the ceiling, I had this, oh my God moment. Because I started seeing all these spools of cable, I started realizing that as soon as I started looking at the interconnections, I said, this isn't a telemetry system. This is like 2 or 3 together. I went down the hall a little ways. There's a power supply into a nutrition room to nothing. And so long story short of that, the first thing I did when I called the rep, he said, I told them not to do this 5 years ago. And I said, I don't want to hear a word out of you. You're in Alabama, get in your car, get out here, we got a catastrophe. But that was one of those moments where they saved a little bit of money, but it catastrophically, I still remember that we're on divert for, you're hearing it completely from the CEO. How did this happen? I have no idea. I wasn't here. I wasn't here when this was installed, but it will not happen again. Budget issues, this was something they say, they saved a little bit of money, didn't go well. Early involvement in the budget process, components, software licenses, anything you can, pretty much a lot of this, you can still get some of it, get around some of it. But data conversion requirements for legacy data, that is a nightmare because anyone have a CMMS system? If you tried to move some of, the bad thing in our profession is we don't speak the same language. I'm in my hospital, you're in your hospital, you're in your hospital. I guarantee if we throw a work order report out to each other, it looks like we're not in the same profession. And I think one of my friends, Vincent Wang, used to say with the coding of technicians, stupid technicians. Everybody uses the easiest coding. So if you're trying to track stuff at one point, somebody like a data miner like him, if anybody went to hit one of his presentations, he is smart. He is one of the smartest men I know. But anyways, data conversion, that is a pain. Just from using that as an example, we moved to a new software. We had to leave all of our stuff in our old system. The last time I migrated one, my goal was I brought everything with me. The company we deal with today, I don't mention names, we couldn't do that. We had to start from raw, basically all of our work orders started from day one. So you have to jump back and forth between systems. Eventually that won't matter because as that equipment falls off the wayside. But, know what you need. What are you going to do with your old data? Installation, remote access, a lot of the stuff we talked about, remediation of software conflicts, annual support costs. That has become a nightmare more and more because I know, won't pick on the company, but I know a lot of these companies basically sell their software as subscriptions, for lack of a better term. So if you do not keep up with, and I won't mention names of companies, but if you go X amount of revisions back, I'll pick on, you no longer have their support. I know that's something you need to discuss. When you buy stuff, like if something happens, where does my data go? If the company owns your data, that's a big problem. I know I always was obsessive compulsive about making sure that if a relationship went bad, you folded, how many companies get absorbed every day? I just found out walking through this hall out here, I've got more information out walking through this hall about who owns who than hadn't heard anything. And it's like, oh boy, I've got a lot of fun when I come back. License costs for expansion, disposal concerns. This is a royal nightmare. This was a valid point that was brought up. Everybody looks in the user manual and says there's installation instructions. The problem is how many people in the past have gone through and asked the vendor, what are the de-installation instructions? How can I be 100% sure? Remember that lovely acronym called HIPAA? Guess what? How do you know that all of this stuff is removed? How are unique, medical device CPUs uniquely identified? The disposal of hard drives, we've got, there's 2 ways that in the past I've used them. One of the departments I had basically the IT division had a chomper. You put it in and to log the serial number, it'd chew it to pieces. They don't have that, that's very expensive. What we do is we basically turn into a termite and we, destruct ours with a drill press. So it becomes a bunch of little pieces. And we document how we take care of it. But also, let me explain to you about one of my fund units. One of my clinics happened to want rid of an ultrasound real quick. They called the guy who took care of their old office furniture and said, get rid of this thing. They took a completely active ultrasound and took it to a landfill. Basically rolled it off. You know, I caught it and made them go back and they had to bring it to us. But basically you had none of the data was verified as gone. They didn't realize that they had to do that. Nobody had ever explained to a practice manager that this stuff stayed. You know, you have to have a process for deleting that. So we managed to get the remains of the device back, pulled the CPU out of it, pulled the hard drive. So, but you know, how many times can you imagine on the news that your hospital comes up and says, oh, by the way, such and such medical system, their CPU was found in a garbage dump or a salvage yard. I've seen my equipment in my first life actually in salvage companies. Like I remember my first, anyone remember electronics for medicine? Please somebody raise their hand. Okay. So anyways, that was the first cath lab system. My first E4M was found when we closed our University of Michigan hospital. It was Old Main, we called it, before we did replacement hospital project. It ended up at a salvage yard on Michigan Avenue in Ypsilanti. I remember driving past it going, holy crap. That's basically a cath lab system completely intact. There's no HIPAA stuff in it back in those days. You know, remember I was mentioning some of the costs right here. This will get you started. This is my fun stuff right here. Survey. What we have right here, we're going to get out of here in 1 minute. Far right is the haunted house going on in Chattanooga. One of the bottom lines is our new telemetry system. Site survey. In-house survey, make sure all blueprints, network closets. This right here is our WIN. This is my eBay ICU. This was the beauty of this. You can't see it too well, but if you look off to the left side of that monitor right there, that red box right there, we had redundant networks going to different sides of the hospital. So if we had a catastrophic failure on one side of the hospital, everybody just walked over and switched the wires. Beauty and the Beast. On the left is me, on the right is IT. So that's mine. Challenging areas. That is where we brought that Sprint network through. That is a stairway. Lost in translation, I'd like you to meet my two bookmarks, you know, basically my bookends. We had a discussion, this is the last slide, that during that telemetry install, we needed a core drill. First thing that engineering did was yelled at me and said, you are not going to drill a floor. I said, that's not what I said. I said, they need holes here. They said, we control that. I said, cool. You know, work with the vendor, get these done. Well, one night, got a call. We had all communications go. We have a patient tower, ninth floor through 6th floor. All communications down on the 9th floor. All communications on the 8th floor is down. 7th floor, kept going. I'm getting ready to leave. It's a late night. Guess who I run into in the elevator? The guys who are core drilling. It doesn't dawn on me that any of this is related. So what happened was, got a call and said, you know, you're core drilling. I said, no, it's not my core drilling people. It's facilities did the core drill. So I went out the next morning and said, surely they picked up at least the cores. Those are my two souvenirs.